Hi, everyone. I'm Ileana Piña from Thomas Jefferson University, and this is my blog. So I have with me today Barry Borlaug, who is from Mayo Clinic in Rochester, and he is well known for his description of the exercise hemodynamics of HFpEF patients. It's a diagnosis that some of my colleagues have trouble wrestling with because the patient may show up with hypertension, or they may show up with diabetes, or they may show up simply because they can't breathe and they're obese and they're not walking very well. These are primarily women, usually older women, who have a lot of comorbidities. And now we have the SGLT2 inhibitors in the guidelines for this group of patients, a HFpEF, which by definition, and our new definitions today, is an ejection fraction of over or equal to 50%, which I think fits what Dr. Eugene Gronwald has been saying for a long time, that that's the real HFpEF. And probably one of the best diagnostic things that we can do for these patients is to figure out what their left atrial pressures are with activity. And that may distinguish them from other things. So how do these SGLT2 inhibitors work? We have all these slides with all these mechanisms, but nobody knows. And Barry and his team really took this on and studied it, did a trial called the CAMEO DAPA. So Barry, first of all, welcome. Our audience should be very interested in this. And tell me about how you did this.
Sure. Well, thanks for having me, Ileana. As you know, HFpEF is a hemodynamic disorder fundamentally characterized by high filling pressures, rest, and then especially with activity. And we know that SGLT2 inhibitors work. We don't know why. So we were hypothesizing that there may be hemodynamic benefits that we would see on both rest and exercise hemodynamics. So in this study, we took patients with HFpEF EF50 plus and did a baseline invasive hemodynamic exercise test to maximal effort. And we also did a direct measures of blood, plasma, and red blood cell volumes, body weight, and other sort of standard measures. And then we randomized them to treatment with dapagliflozin 10 once daily or placebo once daily, double blind, for 6 months. And then they came back and did another test, another invasive hemodynamic exercise test, and another blood volume test.
How did you measure the blood volume?
So there's this radio-labeled indicator dilution technique. The manufacturer is called Daxor. It's a test it's a nuclear medicine test that we use. It's nice because it gives you a direct it's not an estimate of plasma volume, which is what we usually kind of have to look at.
That's what we live with the estimates, yeah.
Exactly. So, and as you know, these drugs cause osmotic diuresis and natriuresis, and there's lots of thinking that, the reduction in plasma volume might be key. So we wanted to look at that. So we enrolled 37 patients, 1 withdrew, 36 completed. And we found that as compared to placebo, treatment with DAPA reduced resting and exercise wedge pressure. The effect size at rest was 3.5 millimeter mercury reduction, which doesn't sound like a lot, but that's about 20-25%. It's a pretty good effect size. And with exercise, there was an over 6 millimeter mercury reduction in wedge pressure, which was very impressive, I think. And we looked at other measures. We actually saw a trend for a reduction in blood volume, which was not significant, but there was a reduction in plasma volume. But it was pretty modest. It was about 170 mils. And we know that the SGLT2 inhibitors also on average in the prior studies usually did about a 1 to 2 kilogram weight reduction. In our study, where the patients were a bit heavier than some others, we saw a 3.5 kilogram reduction with DAPA versus placebo. And the amount of weight reduction was actually correlated with the reduction in wedge pressure, both at rest and exercise, which I thought was kind of interesting too. So I think this sheds some new light on how these drugs work to help people with HFpEF feel better.
What about diuretics? Were they on any diuretics at all? Because it sounds like if I gave a diuretic, maybe I'd do the same thing.
Yeah. about the usual proportion that you would see in like more of an ambulatory HFpEF group. I think about 3/4 or so were on diuretics. I actually took a look to see if there were any changes during the course of the study, and there really weren't. I mean, so a couple people went up, a couple of people went down in
In
both
spite of
groups.
diuretics.
Yeah, with diuretics.
So in spite of the loop diuretics, any of them on things like our spironolactone or an ARB or any of those?
Yeah, it was pretty typical background therapy with MRAs. I want to say, maybe a little lower, 20-30%. Unfortunately, that's often what we see in trials these days, even though the drugs look pretty good. But a majority were on ACE or ARB and beta blockers.
So
Beta
they had
blockers, of course, with
good
evidence.
background medical therapy.
Yeah.
What was your mean EF?
It's about 61%. And they were all real HFpEF.
So this is the real McCoy, yeah. And mostly women, right?
Yeah, 2/3 women, 70% obese, and the mean BMI was 35, which is pretty typical of HFpEF, in the US. Seems like it's a little lower in Asia and Europe, but for us, it's pretty typical, I think.
What about their NT-proBNPs?
Modestly elevated, but not markedly elevated. And, we know that that's often the case in HFpEF related to the obesity, we think in large part. So, and their filling pressures were only modestly elevated at rest. I think on average it was about 16 millimeters of mercury at rest, but above 30 with exercise. So these are like floridly volume overloaded patients. These are more the typical kind of ambulatory patients with exertional breathlessness.
So what do you think the drug is actually doing? If they have been on diuretics and that didn't change much, but that's still an impressive drop in filling pressure, right?
Yeah, I think part of it is related to sort of a diuretic type effect, and I think there might also be changes in the distribution of blood volume. The venous capacitance, the stressed blood volume versus unstressed volume. And then there also may be myocardial effects, and we didn't really weren't really positioned to see that, but there's evidence that these can also help that. So by enhancing myocardial function and favorably modifying loading conditions, I think that the total sum of all of this leads to a hemodynamic improvement.
You did have a drop in weight too.
Yeah.
Even though it's modest, that's still more than, if I give a loop diuretic, I may, at home, I may have to lose maybe a couple of pounds, but I think you had a much more dramatic drop.
We actually did DEXA scans. We haven't reported any of this yet. The manuscript's getting ready to go out, the initial one, but we saw reductions in fat mass too. So it's not just fluid. There was actually
something metabolic going on. I've thought that these things have something that happens so quickly, that the curve split apart so early. There's something metabolic going on.
Yeah.
What it is, we're not sure. So what's next? What are you going to do next?
Well, I think we're not planning a follow-up with DAPA. I think we're going to do more analyses from these data, which we haven't had the opportunity to do yet. We're going to look very carefully at metabolism. And as part of this, so the study CAMEO is cardiac and metabolic effects. And so far, we've looked mostly at the cardiac effects. We also, working with my colleague Mike Jensen at Mayo, are taking a very close look at glucose and fat oxidation. And we actually measured both labeled and unlabeled free fatty acids and glucose, ketones, and other metabolites, both in arterial blood, and also in this study, actually, we cannulated the coronary sinus. So we have coronary sinus effluent blood, so we can look at transcardiac uptake.
You hardly ever see that. You should be able then to do some metabolomics.
Yes.
Right? Between, the coronary sinus, the downplay of all the blood in the coronary tree. That's great.
Exactly. Yeah, exactly.
Well, it will be very, very interested. I hope you come back and tell us about that. I'd
be happy to.
I think in summary, we all think about, oh, really, we're going to start an SGLT2 inhibitor for HFpEF? Really? And yet you see, both the Emperor and the Deliver trial having these curves that just split apart within the first 3 months. And you think, what the heck is going on here? And it's a group of patients, and boy, are they hard to identify, and boy, are they hard to treat.
And then,
And they often get lumped in, even in the hospital, without the right diagnosis, which I think that's where the phenotyping that you and I have talked about before.
yeah.
I think we need to really start here. So phenotype, maybe that's something you can add to this, is to
Uh-huh.
metabolomic phenotyping, which may be quite different.
I agree.
Great work, Barry. As usual, I always quote you to the fellows here about, you really want the diagnosis of puffer, let's do it right. That catheter in that left atrium and mimic the Borlaug lab. So thank you for joining me, and good luck. And I'll be looking forward to seeing your manuscript. And to my audience, I hope you find this helpful. I hope we remind you that it is in the guidelines, and that we do it as a class effect. Barry's work today was on dapagliflozin, but the guidelines have taken this as a class effect, and we also have empagliflozin approved for HFpEF as well. And there are a couple of others coming down the pike. I think we know that canagliflozin, sotagliflozin, they're each a little bit different, but still within that class effect. So I hope that you use it on your patients, apply the guidelines. That's why all this work is done. And I want to thank you for joining me today. Ileana Piña signing off.